Hello and welcome to yet another conversation on industry leaders who are taking over the world by storm, country by country. It's time for half an hour of Captains of Industry, a CNBC Africa exclusive. Now, in Rwanda in 2008, the country spent 9.7% of their expenditure on healthcare. Around that same time, it was mandatory for every individual in the country to ensure that they had health insurance. Fast forward 4 years later, in 2012, only about 4% of the general population was uninsured. Let's keep the couple of years that happened after that. In 2017, we have digital disruptors, and we have a lot of companies that now came into that same space to ensure that they provided the best healthcare solution for the community and the world at large. One of such disruptors has been a digital healthcare company called Babyl, and today I have the pleasure of joining on the set the CEO here, Tracey McNeil. Glad to have you speaking to us.
Thank you, George. Of
course, from the introduction, 4% uninsured by 2012. That would sound like what convinced Babyl or management to have the company here in Rwanda. But according to a conversation that we had before, that wasn't the reason why you actually set up. Just help us understand how it came about to having you here.
So like most things in it, and in life, they often happen by chance. So we were very lucky when we launched Babylon in the UK that Ambassador Williams, who was then the Rwandese ambassador to the UK, was in the audience when Babylon was launched. And he went, wow, this is exactly what we need in Rwanda. And we went, really? And Rwanda wasn't, the kind of next place we were thinking of going to.
You had never been here?
No, I'd never been here. Obviously heard about it and heard about its history. So, but he kindly invited us here, and I came with Ali Parser. He's the founder and CEO of Babylon globally, and we came here not knowing at all what to expect. And we found a country that is forward-thinking with an amazingly focused leadership, and that want to be a digital hub of East Africa. And we want to globalize healthcare and put healthcare and affordable healthcare into the hands of those that need it most. So you suddenly go, wow, there's amazing synergy between what we want to do and what Rwanda wants to do. And then I kind of kept coming back every 6 or 8 weeks and getting really excited and thinking this could be an amazing partnership.
All right, now I managed to stalk you on LinkedIn, so I understand how far back your experience goes within the industry. You have decades of experience, and probably I'd just like to get your perspective on what was the general sentiment, if any, about developing or sub-Saharan African countries in the industry, in the healthcare sector?
Yeah. I think you kindly told me earlier, George, that actually my experience predates you being a child, probably. So that gives you some idea of how long I've been working in healthcare. So I think Babylon has a passion in terms of, as I said, putting affordable healthcare into the hands of everyone globally. So that means that Sub Saharan Africa is a big place for us to actually introduce digital healthcare. So what we know is that healthcare, 80% of the cost of healthcare is driven by doctors and nurses. So, and understandably, they're highly trained professionals and individuals. But actually, having an affordable solution means that you can't scale the doctors and the nurses. So how do you take those skills and turn it into an artificial intelligence and a digital solution, and then put that into the hands of the population in Sub-Saharan Africa?
How was the progress getting over the skepticism that patients need to physically see a doctor to get the proper diagnosis? That
was something that I pondered on a lot before we launched the service here. So you can have a great product, but how are you going to get people to use it and actually change habits? And we had an idea what the adoption curve was going to be like here. And there's always a kind of white coat syndrome and a kind of stethoscope approach to medicine, and if I haven't seen a doctor in a white coat and he hasn't laid hands on me, then it's not good medicine. So I was personally worried about that. How fast would an average Rwandan in a remote area use a digital solution? And it's honestly, George, the story has been amazing. We did some activation events. We went out into rural areas. And we had some singers and dancers, but they were kind of rapping to Babyl and how we use it, and we got people to register. And the adoption curve was enormous. So I'm told, I'm not a statistician, but
in 2016, right?
Yeah. So we launched in September last year. So we're told, and I have no reason to doubt it, that the adoption curve here was faster than mobile money and M-Pesa in Kenya, for instance.
Oh, right. So the numbers were, was it 600,000?
Yeah, so 600,000. Today we've got 600,000 registered users. We were registering up to 5,000 people a day.
Oh, during inception?
Yeah,
during its inception.
For the first 6 months we ran the service free, because exactly for the reasons you said, I wanted to understand, and the team did, what the adoption curve would be like, would the technology work, and was it scalable? So one of the ways to do that is to offer the service free.
Let me put you on the hot seat now, because the company itself got a sizable amount of funding, and when it transitioned now from the free session, probably we could call it the trial period for the first 6 months, and then transition to an area where it was not entirely free, there was the concern about why you would charge to provide such a service, yet you were well cushioned financially. Just help us understand the rationale behind that.
So we want to. So we were very happy to offer the service free, and we're very fortunate in Babylon that we have amazing investors. So we wanted to offer the service free so that we could test the three scenarios that I talked to you about, the three theories. But actually, healthcare is only of value in the developing world if it's sustainable. And it's not sustainable that it's funded by private institutions or even donors. And so the way forward is about public-private sector partnership. So there'll always be a small number of people in the developing world or in countries like Rwanda who can afford to pay for their own healthcare. But and we've been experimenting with that. We're new, so we've been looking at pricing. How can we make it accessible? How can Babyl be affordable to a mass population? So we've set the price very low. Obviously, we're not seeing the same numbers that we were when it was free, but that's acceptable and that's understandable. But what we're really here to do, and that the government is supporting us to do, is to be part of the National Health Financing Scheme here, so the RAMA and the Mutuelle scheme. I'll
definitely have a lot of questions for that. I know we tracked that when we had the Forbes and the Health Summit in Nairobi. But let's move on now to, okay, so you transitioned from the UK and you came here. A bit of your personal life. So you had to juggle leaving the family and coming to Rwanda. So how was that, trying to balance the two?
Yeah, that's been a really, really fascinating journey. I sometimes feel I could write about that extensively, but yeah, so I talked for years about my passion for Africa. I worked for a big NGO before, and I kept saying I really want to live in Africa, and I kept saying to my kids, Jack and Molly, I really want to live in Africa. And then in the end, I kind of got a bit sick of hearing myself say it, thinking actually I either need to stop talking about it or do something about it. So Babylon gave me the absolute opportunity, and Rwanda. And it's been a professional journey, but on a personal front, it's been a real journey. It's hard when you leave behind the people that you're close to, that you love, that you care about. And I lived in and around London for 35 years. I'd travelled a lot, but I've never lived anywhere else other than the UK.
The reason why I brought up family is because you, of course, came here and you had to build your own family. How big is the team?
The team here is, we've got about 50 people now, if you include the sessional nurses and doctors, and the core management team is 20 that haven't, we take all Rwandese doctors, but they need to have at least 5 years post-registration experience. Secondly, they also need to speak 3 languages, obviously the local language, Kinyarwandan, French, and English. Although it's fair to say that 95% more of our consultations are in the local language, which we'd expect. But then one of the interesting things, George, is that we really test them on their customer care skills, because we talked earlier about you sitting in front of a doctor, and obviously you hope they make eye contact with you, they make you feel welcome. And when you're in that space with a doctor, it's very easy to make the patient feel at ease. It's really different on a digital platform where you can't see the doctor and the doctor can't see the patient. So how do you interact with a patient really quickly and put them at ease and they can't see you smiling, but how do they know that you're kind of interacting with them and making them feel that actually they can talk to you about something that's intimate about their health problems or issues that they have. So the customer care training we do is also really important. But what's been amazing is that we audit, because all the doctors' conversations and nurses' conversations are recorded, but then we play them back to the doctors. And so
they can assess themselves, right.
So how often does a doctor in a traditional consulting room ever get to listen to what they said to a patient? And actually that's how the doctors learn most. And the Rwandan doctors here have a real appetite for that. And then we get them to do their own review. So Dr. Patrick, our medical director, reviews them himself, but then we give them protective time and we say, right, listen to 10 of your own consultations and score yourself. And you know, George, they're toughest on scoring themselves.
Exactly, I could understand. Have you received any concern or any sentiments that most doctors or nurses want to come work for Babyl because it means they work half-time or not full-time, but they still get value addition or the cost benefit of it?
So what I think we're doing is we're creating an alternative source of employment, if you like, supplementing their income. So what I agreed with the Ministry of Health here, and I felt that it was really important from the very beginning that we weren't going to deprive the good hospitals here and clinics of the scarce resource of the doctors. So we don't employ doctors here on a full-time basis, they work on a sessional basis, apart from our full-time medical director, of course. And so they have to sign a contract with us which says that they, first and foremost, they cover their hours that they're expected to cover in their Ministry of Health hospital. And then they work between 4 and 8 hours a week for us here. And you ask them yourselves, as there's a number of them here running sessions today, but what I believe they like about coming here is they're learning new skills, they're learning digital medicine, they're learning about customer interaction on a digital platform, they're learning about their own skills, as I just talked about, and what I get real pleasure in is they take those skills back to their home hospital. And we create, you can see, from the office here, we're creating a different environment in which people work.
Just at home.
Yeah.
All right, I'll also take a short break. I've been speaking to Tracey McNeil, CEO of Babyl, just helping us understand how the company has picked up within the healthcare sector here in Rwanda. Time for a short break. When we return, we focus on major leaps that the company will engage in. A key conversation we'll be having is artificial intelligence and how exactly it will be absorbed into the company's business model. We'll be right back. Welcome back. You're still with us here on Captains of Industry, part 2 of our conversation on the healthcare system here in Rwanda. We've been speaking with Tracey McNeil, who's the CEO of Babyl. And now, Tracey, before we left, we mentioned that we would touch on the artificial intelligence and how Babyl intends to leapfrog. Let's review. As of January, Babylon had raised, in the UK, had raised $25 million in funding from its A-series round. April 2017 raised a further $60 million to develop its artificial intelligence capabilities. That's a huge amount of money. We'd like to understand the expected impact it would have and where we are with developing AI.
Sure. I guess it comes back to the affordability question. So, the doctors and nurses are not scalable. So how do you take a doctor's and nurse's brain and build it into artificial intelligence and machine learning and predictive learning? So I'd love you to see our London office. There's over 150 scientists and doctors working there, and they're building a doctor's brain. And so we call it. So the artificial intelligence tool is called Chatbot. And so how we're using that funding is to build that brain. But then what's important about that is how do we use that in a real context, which actually improves diagnosis and hopefully changes people's lives. So I'm really excited to say for the first time we're going to be using that artificial intelligence tool here in Rwanda. It's very simple. You put in a series of questions, so the patient will describe their symptoms. And then that machine learning is working in the background. And then it gives the patient the diagnosis and the treatment that it needs for that condition.
I'm sure you've been asked about the applicability, knowing very well the penetration of mobile here, at least the smartphone penetration, has been quite an issue. We're seeing 50% of the global population is still not in a position to fill this gap using mobile technology. In Africa, the numbers go way higher. How do you answer to such a rhetoric?
Well, so we've done two things here, really, George. One is that the digital platform that I talked about that we launched in September last year, where we've got the 600,000 users, that is on a basic feature phone. So what we've done is we've taken as much of the functionality as we can from a smartphone and put that on a basic feature phone using USSD code, because we know that that's how 85% of the population here use a mobile phone. And actually that's the population that we absolutely want to target and provide digital healthcare to. But we're now, in a way, even in a year, we've gone beyond that and now talking and excitedly about artificial intelligence and how we now put that into the hands of the population here. So we can't do that, as you say, because the smartphone penetration is low. We can't give it to individuals. We do in the UK. So here what we're doing is we're putting it in the hands of healthcare professionals as a first step. So we've got agreement with the government and RSSB here that we'll be using our artificial intelligence tool, first of all in our call centre here for triage, but then we'll be putting it into health posts and looking at how that can become an effective tool for basic healthcare providers to improve the diagnosis and treatment of patients.
Well, in terms of probably the magnitude of, if you were to calculate how thorough the system is when you're transitioning from medical triage to the AI diagnosis, how would you calculate that?
Really interesting question. So doctors and nurses, and I trained as a nurse many, many decades ago, as you reminded me earlier. And we're not always accurate. We're human beings. So doctors are probably 70% accurate, 70 to 75% of the time. But that's not because they don't want to be accurate. It's because they'll be treating some things they haven't seen before, or they miss things, and that's perfectly reasonable. Doctors generally do most of the time an amazing job. But actually, machine learning, what we're finding is being 93% accurate. So people still go, okay, but what about the 7%? But I say, okay, but what about the improvement from 70 to 75 to 93? So because, again, you're using machine and predictive learning, which is so much more accurate. So, but again, what we want to what we're doing here for the first time, which is testing that machine learning in the developing world. So we've done a lot of work in the UK, but actually now, for the first time, we're going to be doing that in Sub Saharan Africa, but excitingly here, right here in Rwanda. And we'll be testing that. So we'll be testing the machine learning against the skills and the diagnostic skills of healthcare professionals in health clinics and in our own triage centre.
Of course, there's some issues that you have to tackle that are repetitive. Probably even trying to crack the system or trying to crack the AI spectrum as well. Have those been repetitive, what you've been handling in the UK and here? Is it the same challenges that are being faced?
Yeah, so that's what a lot of, the team in London, they're constantly trying to break the system. We can't put it even into beta or a kind of test environment until we feel that we've been really, really rigorous. So we've got teams of people who are constantly testing our technology way before we put it into a live environment. And then here, putting it in a live environment, we're going to put it alongside healthcare professionals, and we're going to test the accuracy of, what would the healthcare professional diagnose, and what does our artificial intelligence tool diagnose. And also, it's like any machine learning or even our own learning, the more times we do things, the different scenarios that we face. I face different scenarios every day in Rwanda and I learn. So, that's how we learn. So that's also how our artificial intelligence tools learn. So the more information we can put into it from a sub-Saharan context, then the more that machine is going to learn and the more accurate it's going to become over time. But importantly, the more depth it has and breadth over conditions that it's able to treat.
Right. We were at the World Economic Forum earlier this year, and it was a general sentiment when all the countries came from developed and developing, and they said that as different sectors, different countries take up AI, there's the potential of loss of jobs before more jobs are created. On your end, what do you see as the quid pro quo? What will we be losing before we start actually benefiting from this AI?
I guess I need to talk from my personal experience here and Babyl's experience here. So, as we said earlier, we've got over 50 people here working. Our team's growing every day. We've got 300 to 500 sales agents across the country. So, through using artificial intelligence, digital technology, we've become one of the fastest growing new businesses and employers here. And in fact, we've got a certificate there that proves that we were commended last year by the Mayor of Kigali for the work we've been doing around recruitment and employing. So I think new technologies will employ more people, but we're not about taking doctors out of the scenario. We'll always need amazing doctors and nurses. And there's always a place for them. But how can the doctors and nurses need to be used for the skills that they really have, which is around treating complex conditions. There's so much that can be treated really simply using technology. So what we believe will happen is that if we can treat those simple conditions at a health post in a health centre and prevent them becoming more complex and being referred to a district hospital, then those great Rwandese doctors and nurses here can treat the conditions that are really relevant for a hospital setting.
And now we had another issue earlier this year where a new directive by the RSSB that required Rama insurance card holders to only go to private polyclinics or private hospitals had drawn a lot of criticism from private practitioners. What was your role, or what did you make of this particular conversation, and how did you cushion probably your clientele or your investors?
Yeah, I think it's really interesting when I read all about that, because I probably saw it 5 or 8 years ago in the UK when major health insurers are trying to control costs. The costs of healthcare are huge, and so if you're a major insurer in the way that RSSB are, then you have a finite pool of resources that you have to control and treat as many people as possible. But then as a provider, then I also see that the costs of healthcare are also escalating. So we weren't at the forefront of that debate, but our view on that, Babyl's view on that, is that that's exactly why you need innovation and new technology, because it's about affordability, and using digital solutions absolutely can reduce the cost of an average consultation. So an average consultation probably costs somewhere between 5,000 and 8,000 Rwandese francs, so that's £5 to £8, or so up to $10. And we can deliver a consultation for probably around $1. And so imagine how many more consultations we can deliver, and how much more value we can create in the healthcare infrastructure. So we can never replace those face-to-face consultations, as I said, but you need to use innovation and technology and new ways of working to try and manage that pot of funding in a much better way.
What exactly do global parameters look at when they're talking about best healthcare coverage or best healthcare insurance?
Yeah, I think globally people are, statisticians and WHO and others are kind of looking at both, really, George. So they're looking at coverage, but they're also looking at outcomes and quality. So certainly Rwanda rates really highly, and you and I were at Forbes Africa, and Rwanda was constantly highlighted as a country that's got access for all through the health financing system. So that's a really important parameter. And so what's great is that Rwanda has a really good baseline for that. And then what we're looking for is that, how do we measure clinical outcomes? So what are malaria rates, what do they look like? What does TB rates look like? Maternal mortality, child mortality, etc. And again, here the country and the Minister of Health are really, really good at monitoring those. And actually they dig deep and they look at those statistics and look at how they can improve it. And I guess to some extent we're testament of that. We wouldn't be here if they weren't looking at how they can improve health outcomes, how they can use new innovative solutions. So I think you have to, it's a complex picture. Healthcare is always complex, but if you break it down into those component parts, then you want to give patients something that is accessible, that is affordable and that is scalable.
We can't let it continue past that. Thank you very much for creating that punchline, and thank you for creating time to speak to us. I've been speaking to Tracey McNeil, who's the CEO of Babyl. Of course, they've engaged in a race, as she calls it, a global race, but now with Rwanda as the focal point of that conversation after the company set up in the UK as well. That has been half an hour with Tracey McNeil, CEO of Babyl, again, just guiding us as a captain of this particular industry. You've been watching CNBC Africa, first in business worldwide.